Welcome to our first webinar on migrant and refugee women's health, presented by Harmony Alliance and RANZCOG. Before we begin, I would like to acknowledge and pay my respects to the traditional owners of the land on which we meet, the Ngunnawal peoples in my case, as I'm calling in from Canberra. So today's webinar is all about periods and menopause, and I'm very pleased to introduce our speakers today, Dr. Talat Uppal and Dr. Nisha Khot. Dr. Uppal is an obstetrician and gynaecologist who currently works in Sydney at both the Northern Beaches and Hornsby Ku-ring-gai hospitals as a visiting medical officer. She is also director of Women's Health Road, a multidisciplinary women's health practice specializing in obstetrics and gynecology. Dr. Khot is clinical director of obstetrics at Djerriwarrh Health Service in Victoria. She has practiced obstetrics and gynecology in 3 countries, India, United Kingdom, and of course, Australia. Doctors, thank you so much for being here today. We're very pleased to have you. And,
thank you for having us.
And I'd like to kind of start with the basics here and think about, why do women and girls have periods?
Okay, so I've got a little prop here. It's a uterus. That's what's in the center. On both sides are 2 tubes, and just under them are 2 ovaries. And so women and girls get periods every month because this ovary here, or this one, produces an egg every month. And in response to the egg, the lining of the womb prepares for a possible pregnancy. So each month, as the egg is maturing within the ovary, the lining of the womb is preparing for a pregnancy and growing thicker and thicker like a soft cushion. When the egg is released, it gets into the tube and travels to the uterus. However, not all months result in pregnancy. And so when there isn't a pregnancy, this lining that has formed inside the womb then sheds through the vagina out as bleeding. And that is what constitutes a period. For most girls, periods start somewhere between 8 and 16 years of age. That is called the menarche, or the first period. Women will continue to have periods throughout the time when there are eggs in their ovaries, until they reach the point of menopause, which is when their periods stop, usually somewhere between 46 to 55 years of age. Some of the things to think about when you have a period is what sort of hygiene products you use. And there are different options available. You may or may not have seen tampons, really tiny things. They go into the vagina. So that's where they go. That's your uterus on top, the vagina below, that's where they sit. Or you may have seen various different types of pads. Some come with wings, some come without wings, some are thin, some are thick. There's all sorts of different options available. My advice is use simple cotton pads or tampons. Try out different brands to see what works best for you before you make a choice. Some of you may have heard of something called a menstrual cup. This is what a menstrual cup looks like. You can see it's a little cup. And just like the tampon, the menstrual cup also sits in the vagina. So it goes in here and collects the blood. The advantage of this menstrual cup is that it is not disposable, and so it can be reused. So you spend whatever money you spend on buying this cup once, and you can use it for many, many years after. It's really easy to use. There's lots of research that suggests it's safe. So this might be a good option if you want to try it out. Some women feel uncomfortable about putting things into the vagina, and that is understandable. So you don't have to use a tampon or a menstrual cup. Pads work absolutely fine as well.
Mm-hmm. And so, Nisha, how often do you have to change, your pads and your cups and everything?
So the recommendation or the thinking is that once you start to feel wet, that's time to change. And if you are using a tampon, make sure that you change it at least every 8 hours. Because one of the things that can happen sometimes with a tampon is that you forget about it. And if you forget about it, that can cause really bad infections. And so it's really important to remember, almost set yourself a timer that it's 8 hours and the tampon needs to come out. But otherwise, as a general rule, once you start to feel wet, that's a good time to change.
Right. And is it safe to sleep with a tampon in, or would you prefer to use pads?
Absolutely. It's safe to use a tampon at any point. You can use it when you're sleeping. You can use it when swimming, things like that. So they're absolutely safe to use as long as you remember to remove them out in time.
Yeah. Right. And so women tend to have different sort of flows of periods, right? Sometimes heavy, sometimes light. What's considered normal?
So normally what we say is that in a whole period, a woman loses about 80 mils of blood. So if you think about your measuring cup, you generally measure about 100 mils of water to add to things. And so it's slightly less than that. The problem with that is that nobody's measuring how much blood women lose. And so what we say usually is that the first 2 or 3 days tend to be heavier than the following days. You should not lose clots that are more than 3 centimeters in size. So if you think about it, about that size of clot, if you're losing blood that doesn't clot, that clots, that suggests that there might be excessive bleeding. If you're finding that you're changing your pads every few hours, 2 to 3 hours, then that might suggest that your period is heavy. Also, if you find that despite using things like double protection, so some women will use a tampon and a pad and will still leak through the protection they're using, that might be another suggestion that your periods are heavier than what would be normally expected. Remember that you're losing blood, and if you lose blood, that's going to affect your blood count. And so if you are losing a lot of blood every month, you might start to feel tired, you might feel lethargic, you feel you don't want to do things, you don't feel as energetic, and that might be the only sign you have of a heavy period and the fact that you're losing a lot of blood.
Right. And so do people experience heavier cramps or more strong cramps if they're experiencing like a more severe loss of blood?
Not necessarily, but yes, some women can. What's happening is that when your uterus is trying to remove clots, it's contracting. So it's almost like something like a labor. The uterus is made up of a muscle, and when that muscle contracts, you can get pain. And that's what the cramping is all about. And so if you have heavy periods, especially if you're losing clots, the muscle in your uterus is contracting and clamping down to push them out, and that might cause cramps.
Right. Okay. And so what are some options then if women experience heavier periods than what they would consider normal? What can they do about it?
So first of all, if they think their periods are heavier than normal, the first port of call would be to contact their GP, their own doctor, and have a discussion with their GP about what their periods are like. Are they regular? Are they irregular? And what are some of the options that they might have for investigation and treatment? Some of it depends on how old you are when you have heavy periods. So for young girls starting out with their periods, it's quite common for them to have irregular, heavy periods with a lot of cramping. And this is happening because their ovaries haven't quite gotten into the pattern of producing an egg every month. And so when the egg is not produced, then that gives that irregularity of the cycle and heavy periods. For most of these young girls, there's no pathology. There's nothing wrong with them. This is just a normal way of their body settling. Similar things can happen later on when you get close to menopause. Again, your ovaries are not producing eggs every month, and so similarly, you can have irregular periods. Not all women who have heavy periods need to have, special investigations or tests or anything like that. For most women, if you're feeling lethargic, if you're feeling tired, then it's worth doing a blood count just to check if your iron levels are low and if you need them to be replaced. You may or may not need an ultrasound scan to check to see if everything is well with the womb and with the ovaries. Not necessarily though, not all women will need an ultrasound scan. Some of the simplest things that we can do to manage heavy periods is to use some drugs which are called non-steroidal anti-inflammatory agents. Now it's a long name, don't be put off by the long name. It's essentially just tablets. They don't have any hormones in them because I know lots of women are worried about taking hormones. And they can reduce the amount of blood loss by about a third. So they work really well. They're taken only during the periods. They can sometimes cause a tummy upset, but by and large, they're very safe to take. So that's kind of the first line of treatment, if you like, for heavy periods, especially in young girls when they're just starting out to have their periods. There are a few other options, and those involve hormones. One of the easiest hormonal options is to use the pill, the oral contraceptive pill, or the pill that has both estrogen and progesterone in it. So the two hormones that are produced normally by the ovary. And all that does is that it makes the cycle regular and it reduces the amount of bleeding that happens. If estrogen is something that may be contraindicated in some women, and there is a list of reasons why you can't take estrogen, then the option is to take just progesterone by itself. Now, taking progesterone by itself, again, it can be in tablet form, or there are other forms that are really, really effective when it comes to giving progesterone in that situation where are heavy periods. And one of the most effective ways of giving progesterone or using progesterone is to use this lovely device, which is called the Intrauterine Device. I hope you can see it. I'm going to hold it up there. It's a small little coil, and it goes into the uterus or the womb, and it sits inside the womb very comfortably. Hang on a minute. There you go. So that's the womb, and that's the device sitting inside the womb. And what it does is that it makes the lining of the womb thin. And so what happens is that then, because the lining is thin, you bleed less. Also, for some women, you might not have a period at all because the lining is so thin that you don't have a period. Now, sometimes I get asked, isn't that not good? As in, you know, there's this concept of having a period is good for your body. It gets rid of toxins and it makes you feel better. But actually, there is no research for that at all. There's no reason why having a period is good for you. In fact, having heavy periods is not good for you because it lowers your iron levels. But certainly there is nothing to suggest that if you don't have a period, you're going to retain some toxins and fall sick or anything of that sort. So it's absolutely fine to use the coil and to not have periods.
Right. And so is it normal then to skip a period or have periods at kind of different times in your life, and you might miss a few months and that kind of thing?
Yes, that is absolutely right. But remember that one of the most important reasons to skip a period is pregnancy. And so if you are in that situation where you might be pregnant, that is a good time to test and see if you may be pregnant. But absolutely, there are times when you might miss a period. And some of the things that have been associated with missed periods are simple things like stress. You know, for young girls, there's an exam coming up, a year 12 VCE exam. The stress of that can cause a period to be skipped or missed or send all of your cycles haywire. So that can happen. For some women, it has to do with rapid weight loss. So if somebody's gone on a diet and exercise regime and has lost a whole lot of weight in a short time, that might also be a reason why they might skip a period. But my top tip is, if you think you might be pregnant, test to see if you're pregnant.
Absolutely, 100%. And so you kind of mentioned that people get stressed and they might not have their periods at a normal time. Is it normal then, once, you know, that stressor or that kind of difficult event has passed, for your periods just go back to their regular cycle?
That's right, yes. So for most people, once the stress is gone, their periods will go back to a regular cycle. If they don't, then it is worthwhile, again, contacting your GP and your local doctor to find out if there's anything else going on that might be a reason for why your periods may not be regular. One of the common causes for irregular periods might be a thyroid disorder. And so that is a very simple blood test that your own doctor can organize and will also organize management if it's required.
Great. Thanks, Nisha. And so one of the worst things I find about having periods is not so much the blood loss itself, it's all the kind of things that accompany it, like PMS, so premenstrual syndrome. Can you speak a bit about that and what it involves?
So PMS is, like you said, a combination of symptoms that occurs sort of around your period. Hence, it's called premenstrual or perimenstrual syndrome. It generally tends to happen before you actually start bleeding. And you can have things like bloating. Some women have diarrhea. Many women experience mood swings, headaches, breast tenderness. Those are sort of the common symptoms. Now, there's a range of different things that could work, and some of the simplest things that you can do if you are suffering from premenstrual syndrome is to find out if there are any triggers. And for some women, the triggers will be chocolate, will be things like coffee. I know it sounds awful, isn't it, asking people to give up coffee and chocolate because they have PMS, but that might be a trigger, and it might be just worth avoiding those triggers for those few days. Some of the other things that help is just a regular, sensible, healthy diet, getting out and getting some exercise. And I don't mean, you know, like heavy, strenuous exercise, just even going out for a walk regularly. Things like yoga that, you know, help you deal with some of those symptoms might help as well. And then, of course, there's drug management. Now, for most women, drugs are something that they would go, oh my God, I don't want to take even more medication. And that's understandable. But some of the easy things that work are calcium. And so that's, you know, a lot of women take supplements of various types at various times, and taking some extra calcium might help with those symptoms. There are other drugs that can be used as well, not very commonly used. And of course, sometimes it might just be avoiding the cycle completely, might deal with the premenstrual syndrome as well. So things like using the oral contraceptive pill and using it back to back for 3 months in a row might be something that helps with the premenstrual symptoms.
Right. So things like supplements, is that something that you would recommend or not really? So like even
So not really, because some women will say that, yes, I've taken it and it has worked for me. But what we don't have is a lot of research around whether it works for everyone, and also whether it doesn't cause any side effects for everyone. And all of these supplements are expensive. So if you are going to spend a whole lot of money on these expensive supplements that don't work for you, then that doesn't seem like a reasonable thing to do at all. Talat, do you have some suggestions for PMS?
I agree with what you've said. I think that that's very sensible. Yes. No extra ones.
Unfortunately, no. Yeah. And so you mentioned that exercise can help when you're managing these sort of symptoms. Is that something you would recommend in general while you're on your period? Some people say, you know, exercise helps with cramps and that kind of thing. Is that something you find to be true?
Yes, absolutely. So what research shows is that actually keeping up with a regular exercise regimen is good for you on the whole. There's no doubt about it, of course, but it's really good in helping deal with PMS symptoms, deal with menstrual cramps, and generally make you feel well. And like I said before, it doesn't have to be that you run a marathon. It can just be going out for a walk, making sure you get those 10,000 steps a day, making sure you get out for at least 30 minutes. And, you know, getting into the fresh air, sunshine is good for all of us, for our mental health, but it certainly helps with those symptoms. And a period is not a reason to not do exercise. I know, again, that there are lots of misconceptions around, you know, you shouldn't be exercising during your period, you shouldn't be having sex during your period, things like that. But none of these actually have any evidence behind them.
And it is good to see your GP, because there might be some underlying mental health disorder that could be, you know, well supported, and this can be one of the manifestations of that. So it is very important to connect and share that with the GP.
Right, definitely. And so we've had a couple of questions come through, and people are wondering, you know, with mood swings during periods, for example, is there anything you can really do to manage it? I find like I get very irritable, for example, and so anger management, or is there something else that you can do?
So there's certainly counseling can help. There's no doubt about it.
Yes.
Having a supportive family and a supportive partner who realizes that you're on your period and hence you're irritable is a huge help. So,
The
you know,
acknowledgement, yes, and friends.
Yeah.
Maintain friends, maintain connection with family, have a discussion with those around you about how your periods affect you. There are certainly drugs that are available for mood swings, but I know that for most women, they don't want to take more medication to help with it. And so trying to manage it without medication is probably a better option for most women. And doing all of these things might help.
Great, thank you. And so is it also important to remember that generally the mood swings are temporary and they're not really a permanent thing? That's right, right?
That's right. Yes.
Okay.
Yes. There's light at the end of the tunnel.
Great, thank you. And so another question we've had is about menstrual suppression. Is there enough research to support that it won't result in long-term adverse effects?
Like I said, so menstrual suppression of different kinds, and one of the kind of things for menstrual suppression is the use of the coil, the Mirena coil that I showed you earlier, and things like Implanon, which is the device that goes just under the skin. And so all of these are very safe to use. There is no evidence to suggest that they cause any problems for, you know, the rest of your body or for your general health just because you haven't had a period. For some women, menstrual suppression means using the oral contraceptive pill. And like I said, if you take 3 packs without taking the inactive tablets in between and you just take them back to back, then that causes menstrual suppression and you don't get a period usually till the end of the 3rd pack. And again, that doesn't have any long-term consequences on your health. And it might just help you manage certain times in your life when you don't want to have a period, or if you just want to postpone your period and, you know, allow your body to kind of recover from having a really heavy period. It's absolutely safe. There is no evidence to suggest that there's any issues with your health in the long term.
Great, thank you. That's really helpful. And so with Implanon, that's the arm implant, right?
That's right,
Yes.
yes.
We've had a question come through about whether it's normal to bleed regularly when you have that arm implant.
Yes, so for some women, they will bleed regularly. Some women will bleed irregularly and have spotting. Some women will not bleed at all. So whatever pattern your body gets into is completely normal for you. What is annoying is that if it doesn't have a pattern, when you can't predict when you're going to bleed and you have that irregular spotting and you have it for a long time, that's the one that causes most annoyance. And that's the reason women come back and say, look, I can't deal with this, take it out.
Mm-hmm.
And so that's fair enough. But whatever pattern your body settles into is absolutely normal.
And also, a lot of these symptoms actually settle. So when you initially get an implant or get a Mirena, usually I try to encourage women to put up with it almost for 3 to 4 months. And often then at the end of that time, their body has adjusted into a routine that they're more comfortable with, or maybe they have learned to put up with a little bit of irregularity as well. So it's not an instant, pattern that we get. It's helpful to have a bit of patience in that journey.
Great, thanks, Talat. That's really good to know. Another question we've had about cramps, for example. One of the things that you mentioned helps is exercise, for example. What about medication like Panadol? Is that safe during cramps?
Yes, absolutely. It's safe to take Panadol for cramps. It's even safe to take things like Nurofen, and they help as well. And, right at the beginning, I said one of the things that helps with heavy periods is something called non-steroidal anti-inflammatory agents, the long name, but those help with cramps as well.
Is that, like, for example, naproxenic? Is that an example?
Yes, exactly. Because, Amanda, the advantage there is that it's an anti-inflammatory agent, like Nisha has said. So it's not only going to manage the pain, it's also going to manage inflammation. Whereas Panadol is just an analgesic, which is just pain focused. So we can either combine the two if you find that the naproxenic is not enough. Panadol is generally a very safe medication. It's fine to make a combination that works for women, or we can, but my preference would be to use the naproxenic based agent first.
Great, thank you. Yeah, that's good to know. We've had another question come through about trying for pregnancy when you're on the Mirena. Like, when would it be safe? And so how long should you be off the Mirena?
You don't need to be off the Mirena for any length of time. Once the Mirena has come out, it is absolutely safe to try for a pregnancy. What sometimes happens is that you might not get back to your cycle immediately after the Mirena comes out. And so it's probably best to wait till you have a period and then start trying for pregnancy, because then you at least know how pregnant you are and when you might have gotten pregnant. But there isn't any concern of, getting pregnant immediately after the Mirena has come out. It's not a danger to get pregnant at all. It's more from the point of view of practicality, I guess.
Yeah, and in fact for women, because the Mirena IUS is basically, you are fertile when we take it out from that particular cycle. If you're planning a pregnancy, it's often good to start folic acid, to start the iodine, to get your vaccinations in order, perhaps see your GP around a preconceptional counseling prior to pregnancy, so that if you take the Mirena off, you're actually ready to embark on a pregnancy. So it's good to align all those things if you are truly trying to fall pregnant and therefore want to take the Mirena out.
Mm-hmm. And kind of coming off that, there seems to be a little bit of a perception that you can't get pregnant if you have sex on your period. Is that something you find to be accurate?
No. Well, you can't get pregnant from sex during your period because that's not your fertile time, but that doesn't mean that it's going to affect pregnancy or conception at any other time.
Okay.
And occasionally, because women's periods are irregular, we think we're on a period, but it's actually some sort of mid-cycle bleed. So technically the science says you can fall pregnant on any day, but because we may not be perceiving, the periods may not be as the clockwork 28 days that we hope for. But yes, because and the physiological aspect is when the endometrium is shedding, you're not fertile during that time, so you can't. But technically we are taught that you can fall pregnant at any time, only because we shouldn't just have the security that this is our period. Yeah,
that's really good to know. Yes, there seems to be a bit of a perception out there that periods means that it's good to go and you'll be fine, but
generally speaking that's right, but not 100% of the time is what I'm trying to say. Yeah,
thank you, thanks for clarifying that.
It's best to use reliable contraception.
Yes, contraception.
Webinar. Yeah. So in the interest of time, we might have to skip forward a few years and dive into menopause, so everyone's favorite time. And so Talat, can you kind of explain to us what is menopause?
Okay, so menopause, the word is actually of Greek origin. And as the name suggests, the meno is menses and pause means to stop or cessation. And so it's basically the time when our periods are ending. And the big picture around menopause is that the ovaries are basically not producing any more or reducing the amount of estrogen that is being produced. And most of the symptoms that we experience during this transition or the actual menopause and postmenopausal period is because of the effects of the low estrogen on our body. So estrogen acts on all the cells in our body. And when it's low, we basically start feeling symptoms. The symptoms could be vasomotor symptoms like hot flushes or night sweats. They could be urogenital, near the bladder, having more infections, having a dry vagina, having difficulty with sex. They could be mood issues. So people often report that they're more anxious or they feel irritable or more tired, more fatigued. And there could be other general symptoms. Like, for example, some women say, I feel like ants are crawling under my skin, or they just feel, just very, very edgy, or again around the mood angles. So menopause is actually your last period, but when you're having periods, you don't really know that this one is going to be your last. So it's a bit of an interesting mathematics that it's a retrospective diagnosis. And so it's only when you've had a year after your last period that we say you're truly in the postmenopausal, you're truly menopausal. Mm-hmm. So the part prior to that, and on average for Australian born women, generally it's about 51 years of age.
Right.
But as we'll discuss later, certain cultures and certain genetic factors can influence that. So that's just a statistic, which is an average number. Many women become menopausal between 40 and 55 or 60. Actually, it's quite a wide range. And certainly if you become menopausal before 45, it's called early menopause. If you become menopausal before 40, that's a group we particularly worry about, Amanda, because they're very young. And they would have had hypothetically another decade of estrogen, positive benefits in their body, which they've lost out on. So that's a very important group of women. It's a very small number, but they're really important. They're called primary ovarian insufficiency, but they're people to support through the menopause journey. So the period leading up to the final period and the year after is called perimenopause. Mm-hmm. And this can be a decade. So it could be up to 10 years, could be 8, could be 4 to 6. Generally, women get symptoms around menopause for about 7 years, though. That's an average for most women. So the other interesting part about menopause is that a fifth of women go through this journey without any problems. Like, how lucky are they? They don't really realize that there's anything different apart from the fact that the periods are getting, a bit irregular or stopping. So 1/5, 20% are the very lucky ones. Mm-hmm. On the other hand of the spectrum, 20% are actually really, really struggling. So they would have quite severe symptoms that's affecting their quality of life, that is affecting their work, affecting their day-to-day functioning. And in the middle is the large 60% group of women who are basically mild to moderate symptoms. So when we look at menopause, it's very individual because women might have different symptoms. Women have different expectations and what their choices are. So some might be very natural and they don't necessarily want to embark, like Nisha mentioned, not necessarily want to take any medications, want to try other strategies, how to manage it in this period. Whereas others might be, hey, listen, I need a Band-Aid or I need medication to sort out these issues. This is a problem with a solution. What can I have? So women approach menopause in a very different mindset. And our role as clinicians is to say, look, there is a lot of help out there for this condition, and to basically explore all the options and then work with the woman to say, look, what feels right for you? What would you like to do? And how can we help you in that space?
Right. Thanks, Talat. That's really helpful. And so with menopause, just to clarify, you've experienced menopause now. There's no way you're having children after you have menopause, right?
So the deal with menopause is that, yes, once you're 12 months after the last menstrual period and you're above 50, we say, yes, now there's no need to use contraception. Your body has declared itself. Unfortunately, these eggs are, or fortunately, whatever way you want to look at it, are no longer viable. And so therefore, you're not going to fall pregnant. But when you're under 50 and you attain menopause, we still say use contraception for 2 years, because we don't want you to be falsely lulled into the fact that, look, you're no longer fertile, because there still can be the odd ovulation. And the last thing most women want at 50 or 40 something is to necessarily, unless they're specifically trying, is to fall pregnant. And it's so interesting, this journey, Amanda, with eggs. So girls are born with about 1 million eggs. And what a huge number that is when they're a baby. And then by puberty, they've already sort of dropped, those eggs have declined to about a quarter of that egg pool. So they're about 300,000. And that's a mind-boggling number, still so huge. We do obviously have a handful of children. And so you have this very large context of eggs or potential eggs in the ovary. And then what happens is that most women during their lifetime use about 500, maybe 450 cycles of those eggs. And all the other eggs slowly, it's almost like, it's not a nice analogy, but it's almost like an expiry date. And they keep declining. And at menopause, that's when there are no more eggs left. And so therefore there's very low estrogen levels. And it's not only estrogen, the ovary also produces testosterone, which is a male hormone, but that also declines in the time leading up to menopause. So a lot of the manifestations we see are reflective of the hormonal changes in the background within the body.
Right. Okay.
And I suppose it's important here to say that the highest rate of sort of unplanned pregnancies or unexpected pregnancies occur in women who are around menopause, because of this feeling of, oh, I've crossed whatever, 45.
I'm no longer fertile.
I'm not
Yeah.
fertile, I won't get pregnant. And actually there's a higher chance of getting pregnant purely because you have come off your contraception, not because you're more fertile, but you've come off your contraception. And so contraception is very important at all ages and stages in life.
That's right. So until we've truly declared postmenopausal, please use contraception, because like Nisha said, the overall chances are low because your body is stepping down, but it's not zero. And it's quite confronting to fall pregnant in that time.
Yeah. And just to clarify, when we're talking about contraception, we're talking about condoms, birth control,
Yes.
all that stuff, right?
Yes, depending on what the woman wants to choose. Now, there's some things that we could combine. For example, we've spoken today about a progesterone-based intrauterine device, that the Mirena, which was shown to us. Some women would have that anyway, leading up to, let's say, 45, hypothetically. Let's have a hypothetical patient. She's got it in. She's now 46. She's starting to feel some hot flushes. So we can actually keep that progesterone in, and that ticks the mark. That gives us the tick for contraception, but it also protects her uterus. And so if she needs, now we can offer her some estrogen in addition to what she already has, to replace the low estrogen that she's having. So I guess what I'm saying is that the contraception can be weaved into the plan for the woman, depending on what she would like to do. But can I just highlight that even though we've been speaking about low estrogen levels, in reality, there are two female hormones. One is estrogen and is progesterone. So for example, let's say, Amanda, you've got a lady who's had a hysterectomy and she's going into menopause, or she's had the uterus, she doesn't have a uterus. That woman basically needs only estrogen if she's going to choose any menopause hormone therapy. For someone who has an intact uterus, we are meant to use estrogen and progesterone, so two hormones for those women, because we need the progesterone there to calm the uterus down, to try and reduce cancer of the uterus. Or there's another condition called hyperplasia of the uterus. So the progesterone is given to protect the uterus. The estrogen is given to try and replace some, the estrogen, the low levels, and try and improve the symptoms that the woman is perceiving. That is the basic foundation of menopause hormone therapy. But before we come to hormones, I think it's very important to have a holistic approach to menopause management. So very important is to start with lifestyle adjustments. So which start from having a healthy diet. We have really good guidelines in Australian. NHMRC gives us national guidelines which help guide our diet. Exercise, Nisha's already touched on that. Generally speaking, because estrogen is protective of bones, and when estrogen is dropping in the postmenopausal time, our bones become more vulnerable. They're more fragile, and our risk of fracture increases. So for that reason also, exercise is a protection, and especially impact exercise, like for example, jogging, something that encourages the bone and stimulates it to form new bone. And then of course we have general advice, like for example, if hot flushes are an issue, maybe wear layers. So women will often layer and will take off 1 or 2 layers if they're feeling hot, or have a cool drink, or adjust the temperature in their bedroom, or basically take a portable fan with them. So and like Nisha touched on in the premenstrual space, it's exactly the same concept about identifying triggers. And someone said to me that in menopause, we've stopped all the fun stuff, because we say, look, maybe caffeine might not be such a good idea. Alcohol, if you're smoking, please stop it. Even hot, spicy foods could be triggered for some women. So we do then say, maybe go easy on this, because it seems to be triggering a lot of symptoms for you, which then are affecting your quality of life. So that holistic approach around simple strategies around healthy lifestyle, I think, is the first thing to introduce. And also, Amanda, things around things like acupuncture, yoga, mindfulness, some cognitive therapy. These sometimes empower women to face the symptoms that they're having better. They put you in a better headspace to be able to manage some of the symptoms that you're having.
Great. Thanks, Talat. That's a very positive spin on it. I feel like a lot of women dread menopause. I'm definitely one of them who's like, oh, coming. So I think it's wonderful to take a different perspective on it. And so we've had a couple of questions come through. And so I was wondering now as well, since you've got 2 doctors here who can answer any questions you want, any personal questions, I would encourage anyone to just use the chat box, use the Q&A to ask any questions you might be maybe a bit embarrassed to ask, but please don't. It's a very small group today, so please feel comfortable to ask any questions that you want. And so we've had one come through about gaps in our knowledge regarding the experience of menopause and menstruation among coloured women. And so if you were the one doing the research, what would you be interested in kind of researching to kind of add to the existing body research out there already?
Okay, so when it comes to cold women, I would agree that there is definitely a need to empower us by creating more research and more educational resources for them. Because even in my own little anecdotal experience as someone who has an obstetric and gynecology practice, what we've done during the pandemic has been a catalyst for so many of us clinicians to look at how can we do business in a way that is more that reduces face-to-face time, or to just do it in a way that's safer. And so what we introduced in my practice was a questionnaire for women to fill before they came in to see us. And apart from the group that is being referred, we have a large number of people that are referred to us for menopause support. That's a different group. But let's say someone was coming to us for a prolapse, for an ovarian cyst, for irregular bleeding, for other things. Our first question, Amanda, in that questionnaire is, how can we help you in this visit? And often women would focus on the medical parts. And it's not until we ask them, are you having hot flushes? Are you having night sweats? Are you having urogenital irritability? All the specific things around menopause, that they would then volunteer that, oh yes, actually I am having that too. Did you mention it to your GP? Not necessarily. So they did not even think, coming to a specialist practice, that was an important enough symptom to raise. So that really has led me to think that, we sometimes are taught to just put up with it by perhaps elders in our families, or culturally, or some of the shows that we watch, or different sort of, sometimes there's that sentiment where, oh, this is normal, this is just physiological, put up with it. Whereas for some women, it's not. It's actually, they're very, very affected by this. And there are things that we can do to help them. And my other reflection was that, it was interesting that there might be a feeling of taboo, or not necessarily wanting to share that, or feeling like only wanting to discuss what is the very medical part of the consult, what is perceived as a problem, whereas this is not necessarily felt like something they want to volunteer or share. So that was another interesting experience, I think, that I've felt in my own very little experience that I've had. So I think the research should be what are our levels of knowledge? What is our understanding of the options out there? So menopause hormone therapy is an extremely effective way of treating a lot of the symptoms that women face during the menopause period. But because, Amanda, it's not been one of the very stable parts of women's health, because we initially, when I was much younger as a registrar, we used to put women and say, look, this is going to help your heart. And then we went into a phase where we had the Women's Health Initiative being released in 2002, which was a big study that sort of then implied that there might be more harm to women when they come on HRT, and large numbers of women came off HRT. And many clinicians became a little bit underconfident to prescribe it. So we had that vicious cycle of women being symptomatic, perhaps not wanting to reach out, the clinician perhaps not very, very assertive around the options that are available. So a lot of women actually struggled through menopause during that period. So we're trying to raise the awareness now and say, look, menopause hormone therapy in general is quite safe. Yes, there is a slight increase in breast cancer. Yes, there is a slight increase in venous clots. But if you look at the big picture in absolute numbers, this is around 1 in 1,000. So it is not a large increase. And it's only the woman herself that can decide whether this is an important risk for me to not, to withhold something that could help me during this period when I'm very symptomatic. So we need to present the data in a way that is easy for women to understand, particularly culled women. Sometimes might have issues with language, might have issues with health literacy, coming from another country, and different exposure to different screening programs and different health exposures.
I absolutely agree with that. I think health literacy and health systems literacy is so important for women, especially women from migrant and refugee backgrounds. And so another question that we've had come through is about Pcos, for example. Can you kind of explain what that is and, what can be done to manage it?
Okay, so polycystic ovarian syndrome is quite a complex diagnosis. It is quite common, so we find it in up to
Talat, I'm going to hold this bottle up so that you can...
So remember how Nisha said very nicely that each ovary should make 1 egg every other month, so they alternate. Sometimes the ovaries are producing a high estrogen because a large number of eggs, let's say 12 to 15 or even much more than that. Nisha, can you show the ovarian follicles, the eggs on that? Yeah, so sometimes the ovaries are just producing a large number, and what happens is that it's not very functional. So they're not actually ovulating, but they're just growing 12 large numbers of eggs. And what happens is that then produces high amounts of estrogen, which then makes that whole cycle, usually that cycle should be in sync. Our brain, our ovaries, and the uterus should be working in a very functional manner, both the hormones and the way that the lining of the uterus expands to increase, to expect a pregnancy every month. Basically, our uterus is working every month to try and expect a pregnancy. That's what the basic philosophy is. But when you have polycystic ovaries, you have so many eggs producing high levels of estrogen that whole cycle is no longer functional. So we diagnose polycystic ovaries when we've got 3 criteria. There is one, whether the woman's having some irregular cycles. Number 2, if they're having some sort of, male type of like acne, or they're having what we call a lot of body hair, or for example, if we've done some blood tests and their testosterone levels are high, that's the second criteria. And the third criteria is, what does the ultrasound say that the ovaries look like? So if women meet 2 out of those 3 criteria, they're then diagnosed with polycystic ovarian syndrome, which does have, Amanda, some metabolic consequences as well. So these women are slightly higher risk of having diabetes, hypertension. So it's so important to identify them and then try and figure out what the issue is. Is the issue that they need support with weight management? Is the issue that they are wanting to have a baby and so wanting fertility? Is the issue around metabolic changes? So there's some really good information from Gynaecologists. Gynaecologists is a website that gives us information around polycystic ovaries and also around menopause. And by the way, Australian Menopause Society has also got lots of good resources for women. There are patient videos that you can watch. So for both of these, I think this is some good go-to resources, as well as RANZCOG has patient information both for polycystic ovarian syndrome and for menopause that is helpful.
Great. Thank you, Talat. That's really, really interesting as well. And so another question we've had is about the use of calcium supplements for women after menopause. Is that something you would recommend?
So I did touch on the fact that menopause is a time. So let me start by saying that bone is a very dynamic tissue. Okay, it's interesting because bone is being laid down and it's being broken as well at a microscopic level, obviously. So what happens is that when the estrogen in our body actually tries to stop breakdown, it's almost like a soldier that helps to keep the bone intact. Now, when that estrogen level drops in menopause, what happens is that then more bone is being broken down. So you can imagine that the bone is getting weaker. So at any time it's good to focus on bone health, but particularly perimenopause and postmenopausal times are really times that we as women have to think, how do we create stronger bones for ourselves, particularly if we have a family history of osteoporosis. So generally speaking with calcium, the thought process is that if we're getting a diet that is, balanced, that has enough dairy products, for example, cheese, for example, milk, for example, yogurt. If we're having a balanced diet as per the guidelines, the national guidelines I alluded to earlier, then you generally do not necessarily need calcium support. But if you're worried that, we are lacking in any way, or, I think you can't go wrong with taking calcium support in that period. The other thing that it's a very good question, but the other thing is around vitamin D. And sometimes particularly with cold women, we find that sometimes there might be a group of us that might not be, accessing the sunlight as much, or perhaps wearing a lot of covered clothing. So again, that is a space where if you think that there is potential that we are accessing less vitamin D, it is important to get it tested and replaced, because these are all strategies towards bone health for longer term for us.
Right. Thank you, Talat. That is really good to know. And so, Nisha, just to kind of jump back into the whole heavy periods, because I think it's a really fascinating topic, and I think it's something that we don't really talk about very much as women, is a side effect of having heavy periods, excessive blood loss, will that lead to things like anemia?
That's right. So when I said that you might have low iron levels, that's what I meant. I meant anemia. So what happens is that you're losing blood every month, and you're losing more than what your body is able to cope with, which means that then you start to lose extra iron. And then as your iron falls in your body, it also falls in your blood. And hence you have what we call iron deficiency anemia, which is essentially anemia.
Right.
Absolutely.
Can you manage that?
Yes. Absolutely, you can. And so not just iron supplements, but also an iron-rich diet will help. And managing the periods, managing the heavy periods will help with obviously reduced blood loss, and hence you build up your iron.
And so that's a very good comment there, Nisha, around the iron. But sometimes the other angle is to actually look inside the uterus, which is a surgical procedure. Your doctor would refer you to either a specialist or a gynecology clinic around that space. And the purpose is to make sure that we're not missing a malignancy. So we don't want, that there's a uterine cancer, and that's why the woman is bleeding heavily, even though uterine cancer is not common. But sometimes it is more common in women who are bleeding heavily or irregularly. So it might be a warning sign for us. So it's important to see your GP, who then can decide whether you merit an ultrasound. But sometimes an ultrasound is not enough in that space. You actually need to, or some women prefer not to take hormones, or the excellent strategies that have been discussed. And it may be that you're suitable for a surgical, or some of those strategies you've used and you're not, or you used a Mirena and you're not happy, or you've used it and it hasn't worked. Then you may need what we call an ablation or a hysterectomy. And whilst we try to minimize the surgical procedures, there are women who genuinely benefit from this support. And it's important to be aware that, if it's not working, or if conservative management is not for you for some reason, then we can look at some surgical support. And the ablation in a perimenopausal woman is a very good strategy. What we do is we go inside the uterus and we take out the lining, the most superficial lining, Nisha will show us, of the uterus. You see that a little bit darker lining at the end? Yes. And so that's removed with a procedure called a NovaSure endometrial ablation. And sometimes, especially I find for women that are 47, 47, 48, they're going to be menopausal soon anyway, but they're struggling with heavy periods, that might be the band-aid that they need to get them through to 51 or 52 or 53, when they would have then have menopause, they would have shut down anyway. So that's a good strategy to consider. And you can see your GP, who can then refer you to a specialist for organizing that, or to a public gynecology clinic for that.
Great, thanks Talat. And so with periods, we've talked about a lot of different options to kind of suppress menstruation. Can you talk a little bit about some of the side effects that women may experience as a result of those things? So for example, the arm implant.
Yes, so like I said at the beginning, you can have irregular bleeding, and that can last for 3 to 6 months, sometimes longer. And that is probably one of the most annoying side effects that women describe. You can also have other side effects. Some women will say that they put on weight with the Implanon or with the Mirena because of the effect of the progesterone. That's unlikely, because if you use, the dose that is used is quite small. So it's unlikely that it would be just related, the weight gain, I mean, would be just related to the progesterone. You can also have other side effects. Some women will describe dryness in the vagina, will describe skin changes. Some will describe hair changes, and those can be quite common sometimes with use of those different progesterones.
Mm-hmm. Great, thanks Nisha, that's good to know. And so you showed us earlier some of the different options that women can use to manage their periods, the cup, for example, the tampon, the pads. I noticed when you look at the box of tampons, for example, they mention something called toxic shock syndrome. Can you speak
That's
about
right. Yes, so that is because of a tampon that gets left behind in the vagina, gets forgotten. And so you can imagine there's a tampon sitting there, it's full of blood. Blood is a really good place for bugs to grow. And if it sits there for a long time, bugs are going to grow, because the vagina does have bugs in it. You know, that's just normal. That's not because we are dirty or anything like that. There are bugs that live in the vagina, and it's very normal for them to live in the vagina. But once you have something that has blood in it, then it attracts other bugs that can grow. And from there, the infection can spread to the rest of your body, which is why I said it's really, really important to almost set a timer for 8 hours after you put the tampon in, so that you remember to take it out. And if you use it as recommended, as in you take it out after 8 hours at the most, you won't have any risk of infections.
Great, thank you. And so something else I've noticed, for example, just walking in the supermarket, there have been a lot of products now that are very much advertised to women in terms of, you know, personal hygiene and that kind of thing. And so recommending, you know, using scented products on your vagina, for example. Is that something you would find to be healthy? Is that safe?
Please don't use any products that are called feminine hygiene products. You don't need them. Your vagina is a self-cleansing organ. What it does is that it keeps itself clean, it cleans itself out. You don't need to do anything other than wash with warm water. In fact, it's probably best to even avoid soap down there, because the skin there is delicate and you don't need soap to clean it. Just use warm water, and definitely don't use wipes, feminine washes, douches, scented products. None of them are necessary, and in fact can cause harm, because they can cause skin irritation.
Mm-hmm.
And some of these products, Amanda, are not tested by TGA, by our therapeutic goods and organization that actually gatekeeps a lot of medical products for use in Australia. And also, I would say, be vigilant around things that you just order over the internet. You actually do not know how safe these products are, and you might be spending money and doing yourself a disservice by using something that hasn't really been tested much in that space. And I would wholeheartedly agree with Nisha's comments.
Thank you both. Yeah, it's good to kind of clear up these sort of things, because we see those products and we think, should I be using them? Am I not allowed to use them? And that kind of thing. Yeah. Okay, we've had another question come through about hair loss. Is that linked to heavy periods?
Not that I thought that it should be. Hair loss can be one of the symptoms of perimenopause, and that's part of aging and part of the low estrogen profile. Sometimes hair loss can be other factors. They can be genetic factors. It could be, it's more common after just having had a baby. They, you know, and sometimes there are other conditions that you're having, like thyroid, for example, if there are thyroid abnormalities, or some conditions we call autoimmune disorders. But I did not feel that hair loss is necessarily associated with heavy periods. I don't know, Nisha.
No, nothing.
I'm not aware of that
combination
combination
related to either periods or to the use of hormones, either for contraception or for treatment of heavy periods.
Yeah, so I think that's an independent thing. Yes, it's more common in the perimenopause and menopausal time, and there's some strategies around that, but I don't necessarily see that as a symptom associated with heavy periods.
Wonderful. Thank you both for clarifying that. And so in the interest of time, we might sort of kind of wrap things up now. And I was wondering, if there's one thing that you wish women knew about their periods, what would it be?
I wish women knew that periods are just a part of normal stuff. It is a part of your body preparing every month for a pregnancy. That is all it is. There is no scientific basis for having a period every month other than the fact that your body is preparing for a pregnancy. And so not having a period is not dangerous.
And having heavy periods, there's a lot that we can do in that space to help you, especially if you're getting anemic. You don't need to just put up with it. Like Nisha said, such a long list of things that we can do. Please reach out for help. We don't want to miss the cancer. We also don't want you to be anemic when this is a problem with a solution. We can help you with medical managements. We can help you with surgical managements. If you're perimenopausal, or menopausal and having menopausal symptoms, there's a lot menopause hormone replacement can do for you in that space, and there are more and more easier ways to take it. So we can, for example, give it through the skin, through patches, or through creams or tablets, or something in the uterus like we mentioned. So please reach out for the support that is there. We want to look after you so that your quality of life is amazing.